with case control studies. As I said, feel free to go and grab some snacks, stretch a little bit, coffee, juices. Now I'm going to switch over to our colleague, Dr. Alfonso Iorio, who will give us a large group lecture on the 3 components of healthcare decisions: diagnostic, prognostic, and treatment effect evidence.
Good morning, everyone. Happy to be here like last year for this course, which I enjoyed a lot in the previous edition, so hopefully you will make this even better. I find very useful and easier than usual for me to give this lecture after the one that Fahad gave, because that set the stage very well for what we are going to discuss in the next hour. You will see all over this course that we will go in spiral. We will come back to the same concept many times at different level and with different perspective and depth, which is what happened all over clinical epidemiology and critical appraisal, all over one physician career. So hopefully will not be too repetitive. Help me in skipping what you know already or what you think has been covered in detail. I'm pretty sure we will take a slightly different approach. But the objective is the same, and is to build confidence in healthcare decisions. Bridging from reviewing the evidence to individual decision on individual patient. Can you hear me in the back? Yeah, it's, I need to get used to the way this room gives back the voice. It's sort of speaking in a huge mosque or, yeah, much bigger space than it looks like. So, reasoning about confidence in healthcare decision, and also, and specifically, to look into 3 main components of a clinical decision: diagnosis, prognosis, and treatment effect, which is cross-matching the study design in a sort of a matrix. We will need different design for different components. Now, I want to immediately help you understanding what we mean with evidence-based decision-making. You may know of evidence-based medicine. Evidence-based medicine is, as any method, is a neutral concept. Can be used for good or can be used for bad. And we will cover over these 3 days cases where EBM has been used for bad, has been used to support specific interest, individual interest, lobby interest, pharma interest. Not necessarily EBM is a positive concept. And very often it's identified with randomized controlled trials. Fahad has been very clever in putting the randomized controlled trial at the end for 2 reasons. One is usually one gets one concept out of a lecture, so the most likely for you to recall is what has been told in the end. But the other is that it's not only randomized controlled trial. It doesn't all start, it ends with randomized controlled trial. So for EBM, you need at least 4 components. The first component of which is evidence for the context and for prognosis. Is worth or not dealing with a disease depending how that disease affects health. Acne may be a deadly disease for a young teenager, but it's usually not killing people. Some form of cancer are deadly, pancreatic cancer, there is little that can be done unless you are lucky and it's picked on incidentally on a CT and you find a good surgeon that can take it away entirely. If not, there are very little treatment that are active yet on pancreatic cancer. So is it important? Yes, of course, we take care of those patients, but maybe mostly palliation. So the prognosis of the disease and the context are very important to decide which kind of resources and which kind of approach to take to a specific disease. And then patient values and preferences. We not all have the same approach to life. There are risk takers. There are other subjects that are more taking whatever it comes. There are people able to pay for their care, others that can't. Someone puts more value on pain avoidance, and others instead value survival most. This all is part of EBM. And when I say EBM, means that you don't undersee the value of this component, and you try to be as objective as possible and as rigorous as possible in assessing how this impact on decision making at the individual level, which we are interested today, but also at the policy making level. And then, of course, we have evidence for intervention of effect. You may know a diagnosis, you may know what the patient wants, you then have to have some treatment for which there is evidence that it does something. If you have no evidence for effect, well, doesn't really matter to have a proper diagnosis and to know what the patient would like to have out of the treatment if there is no treatment able to do anything. And finally, there are treatments we know are effective, but we also know are very difficult to undertake. Very complex medication scheme. If you think back 10 years ago or 15 years ago when the heart treatment for HIV was launched, that was able to stop completely the progression of the disease, but was a very complicated regimen for medication many times per day and was almost impossible to have 100% compliance. Or diet. There's nothing which is more difficult to adhere to than diet, at least speaking of my personal experience, but I'm sure that for many others, it's easier to tell our patient to be on the proper diet than be on the proper diet ourselves. And all of these goes together in each individual decision, so there is no such a thing of a magic book that tells you what to do with each individual patient. And I'm sure you are happy about that, because there would be no need for doctors if there were books or computer able to make decisions. We are not yet there, and possibly we will never be there, and we will still and always need expertise to put all these components together. Now, I have taken the perspective of EBM, and I've said EBM is not only evidence of treatment, but is all the components I described. Can you see those components in a medical decision for a single individual? May I ask you to help me identifying 5 components of every single medical act. Who volunteers starting? What do you need to make a decision with your next patient in clinic or on the ward? I need 5, please. You need a diagnosis. The evidence for what? Okay, say for treatment. So you need a diagnosis, you need evidence for treatment, then you need the Okay, I'll put that with evidence. To me, evidence is appraised evidence. So I don't count that. Applicable to your patient, okay. It's a good concept, doesn't fill one of my 5. So we might end with 10. But I need some, you wanted to propose someone else? Prognosis? Safety. Okay, so diagnosis and prognosis to me are the context, are the clinical scenario. What are we talking about? And that's fine, that's one component. Then treatment, evidence on treatment, evidence on safety of treatment, fine. What else you need to know? Patient preferences. I'm not sure how much that's relevant in your culture here. I would expect that it is as anywhere else. It might be different the way we communicate our preference in the relationship doctor to patient, but I don't think there's any culture where there is no patient preference, even if that's implicit and you are called to guess. But still, you always, if you don't discuss that openly, you try to fit in the patient's shoes, saying, okay, for this old, frail male, or for this young, still fertile female, what might be more relevant? That's trying to fit into the patient preferences and values. And then what else you need? Economical. You need to think about cost, affordability of treatment. So those are the 4 keystones. What else you need to put all the 4 together? Oh, come on, guys. What you need? Well, you need your brain, and you need your experience. So you need to make good use of those 4 bricks. And that's a different plot of the same component I covered for the general approach to clinical epidemiology. This is Alba Di Censo depiction 20 years ago of clinical decision making at McMaster. So you need the clinical state setting, the circumstances, so diagnosis, prognosis, not only diagnosis of diabetes, but are we speaking of diabetes in a 7-year-old, is a type 1, or is diabetes in a 75-year-old on prednisone for some malignant hematology disease? Completely different approach, still diabetes, but the circumstances are different. We need research evidence, we need patient preferences and values, we need some reasoning about cost and resources, and we need to put all together. So, which order doesn't matter, but the basic concept is that however you put these together is with your clinical expertise, is not just evidence. Evidence alone doesn't make any decision, which is why we are happy to be doctor. I didn't introduce myself because Fahd did, but I'm an internist by training. I'm mostly practicing with bleeding disorder patient, congenital bleeding disorders, hemophilia, acquired hemophilia, von Willebrand, and so on. But I'm an internist by training and a clinical epidemiologist by profession. Evidence doesn't make decision alone. We have to find our way out of the maze. And that's why you are offered or strongly invited to take this course. Now, as you may guess, I'm not Canadian, right? I'm Italian, pretty deeply Italian. But I'll take the Canadian approach to start using an example. So you are in a ICU rotation and you are admitting a young male presenting with shock few weeks after reconstructive end surgery. He has been found unconscious at home by his wife coming back from a 3-day visit to her family. Hypotensive, hypovolemic, hyperpyretic. I will fill with you the question, So population is standard adult male admitted to ICU with hemodynamic compromise. Intervention, we are interested in diagnosing sepsis. So does using procalcitonin as compared to CRP or ESR increase the precision of the diagnosis of sepsis? And really, we don't look at a long time frame. We want to know now, in 10 minutes, as soon as the result is available from the lab. So this is a way of formulating a question. I'm sure you are familiar already with the PICO formalism, and Fahad went over, but this is important because it helps you finding the answer to your question. And if you can't frame the question, well, there's something wrong there. If you are not comparing anything, there's no question. So there's nothing for you to answer. So move to something else. If it's important for you to decide if this gentleman has or not a sepsis, because that will drive your treatment, then ask the question. And if you are thinking about a test and you want to know if that test changed your idea, well, then you have to be able to formulate a question. Do I ask procalcitonin or CRP or nothing? I just use the temperature. Whatever you decide is okay, but in making decision, you have to have a comparator of some sort. So let's assume this is the question we want to answer. We do the usual thing. We go to the literature, and we do a search, and we are lucky enough to find a systematic review. Every systematic review has a flow chart. They start from thousands of articles, read through, exclude some, keep others, and you'll see that there is some evidence. There are 25 studies that were performed to try to answer if there is any added benefit of using procalcitonin. 6 of these studies are about patients like the one we are interested in, and 15 of those studies did the 2 tests at the same time. Is this all you need, or you would have needed another line in these slides to know if this systematic review is good for you? This is where critical appraisal becomes important, because since your population is adult admitted to ICU with query sepsis, you want some of the studies that are in the second group, the 6 studies that have information specifically on sepsis, and then you want some of those having also the 2 tests done at the same time. A good diagnostic study has always the 2 tests together. You will see later on in this course, and I'm just dripping here and there some concept. We will come back. But the concept is we have a question, we want to make a diagnosis, and we need to go find in the literature something that has the proper characteristics. So in this case, the study should enroll patients like ours and provide the 2 tests at the same time. Let's diverge for a second. Who of you know who these 2 are? Who? Who? No, you may be right or wrong. I mean, that's not covered in your training, so you may try, but I didn't hear. Yeah, so they are both strongly linked with McMaster. But any one of you recognize any of them? I can help you. You are not supposed to know. This one on your right, on this side, is John Evans. He founded the McMaster Medical School, and he wanted McMaster Medical School to be problem-based learning since day 0. No formal teaching like this. Students, they get around with some facilitator that have no idea what they are talking about, and they try to solve problem. Because that's what you will do later on in life. It's a very hard way of learning medicine. After 4 years, you know a little less than they know it in Toronto or in Boston, where you are given the right information, but 10 years after, you know much more because you have learned how to answer your question. The one on the other side is David Sackett. And David Sackett was hired by John Evans. He was a young nephrologist in Buffalo and was hired with the scope of building clinical epidemiology in Canada. There was no clinical epidemiology department there. And he created EBM. There was no EBM before him. He came up one day, was unclear. He was with Gord Guyot, and among the two of them, they came up with the term evidence-based medicine. Each one of the two said, I did it, but that doesn't matter. Who are these two? These are slightly younger. You know any of them? So, again, the one on the right is Gordon Guyot. He was teaching this course, the one on this side. Isn't this right? Oh, my right, your left, good. So, on this side, sorry, even here, John Evans is on this side and David Sackett is on that side. Here instead, Gord Guyot is on this side. The other one is Brian Haynes. So, in a way, I took over this course from Gordon Guyot, and I took over the unit, the Health Information Research Unit at McMaster from Brian Haynes. They had created two different streams of EBM. Gord Guyot implemented the concept of teach how to fish. Clinical trials, the JAMA user guide series, the book you have in your package. This is teach physician how to appraise the literature, which is part of what we will be doing over these 3 days. You need to be able to tell this is a good study, this is a bad study. Brian Haynes was more for the pre-cooked fish. I'm sure you like to go fish your own and then clean it and then cook it, but you need a weekend for that very likely. I don't know how easy it is to fish here, but in our places you have to drive a few hours before you can capture fish, catch fish that you can eat. So pre-cooked fish is pre-selecting good quality evidence, packaging it for use. And that's not bad at all. You need both. You need to do the last mile. That's why I started by telling you, you always need expertise in the end. But you can start from pre-appraised evidence. And you can build on what, for example, the Cochrane collaboration does in selecting evidence for you. And evidence can be thought of as a pyramid where you have studies at the very basic level. It's important for everyone to go through appraising studies, at least one in life. That's like seeing a specific clinical condition with someone teaching you about it. You fix concept that will stay there forever. But then there is no need of reading all studies of treatment of myocardial infarction. If there are systematic reviews that have already summarized all the evidence, well, why not to use those? So you may move one step up and find a good systematic review. That saves you tons and tons of hours. If you were to read all the studies, do all the appraisal, come up with a synthesis, you will not see any of your patient on the ward or in the clinic. So whenever there's a systematic review, good to have. There are guidelines. What's the difference between systematic review and guidelines? Well, guidelines, they try to bring in generic assessment of cost, patient preferences and values, other component of the decision making. Is a panel of people sitting around a table, looking at the evidence, looking at the other component and telling you if the patient is like this, if your healthcare system is like this, and if the patient preference is this one, that's the decision that you would like to take. So these all help you getting to the decision. Summaries, what are summaries? Summaries are collection of recommendation. For example, UpToDate, Dynamed these are what we call summaries. And systems, I put question mark because I'm not sure if they exist, but system ideally is when all this evidence is first summarized, then broken down in the individual component and linked to electronic medical records, so that while you type in diagnosis and the lab test result, concept pop up saying, oh, by the way, you should consider this disease. Oh, you are prescribing this medication, this patient is already on this 4, something is not going well together. We don't have those, but ideally, with the progress in the classification of evidence, we will get there. Not in our career span, likely, but we will. Now, this is the most recent classification of evidence that Brian Haynes and Brian Alper, the founder of Dynamed, had published this year. You will see in the literature search session that you can find evidence already organized along the pyramid. This is what my unit does. We read through 120 journals, we select high-quality paper, we send them around for judgment about clinical relevance and newsworthiness. When we get those back, we put them in a database to fill some level of this pyramid. But we also provide that evidence to publishers and editors of up-to-date and Dynamed, best practice, clinical evidence, many of the textbooks that are point-of-care textbooks and are evidence-based, with the idea of disseminating evidence as much as possible. And we give you back, if you search for whatever, all the entry point in textbook, in ACP Journal Club. Who of you knows what ACP Journal Club is? Let's see if you are awake. Who does not know? Who's ACP Journal? Okay, good, so you are awake. ACP Journal Club is a monthly issue of Annals of Internal Medicine where we publish 10 abstracts of high-impact articles that have been published in the previous months. And we do a new abstract where we do not put in the abstract what the authors put. You know, you have to get your paper published, so you try to massage the data in a way that they look good. We don't care, it's published already, we have those 10 spots. We select very high impact article and we create a new abstract, standardized, where we report the information always in the same way, and we report it as it is after having done critical appraisal. If you want to test your capacity of doing critical appraisal, you pick one of those issues of Annals of Internal Medicine, you read the article on your own, you make your own idea, and then you read the abstract. And I can promise you that depending on your level of expertise, 2 in 10, to as high as 5 in 10, you will find different conclusions from your reading and our reading. Just because you need to get used to what the flow are in a study and where the tricks are in representing the result. Very often our conclusion is not the conclusion of the author. Maybe they pick a secondary outcome, they hide the primary, and so on. So if you search in PLUS, and you can go to that address, it's free, you register, you can then also subscribe to receive alerts in your own discipline. You are pediatrician, surgeon, dentist. Well, we don't have a lot for dentists, but gastroenterology, endocrinology, cardiology, you can register and get as many articles as you want that are just published and selected to be high quality. So if you search, we give you the entry point in the summaries, then we give you the synopsis, and then we go down to the studies, and in the end, we search for you PubMed, so that you don't need to go and search in different places. You do one single search, and you find all the results, and you start from top. If you find the answer to your question in Dynamed, good for you. If not, you can continue down to systematic reviews, studies, and so on. Now, in our systematic review that we have found, there is, of course, a forest plot. We will dedicate time this afternoon to read what the forest plot is. But is this what you expect in a diagnostic study? You expect to be able to decide if doing CRP or procalcitonin by looking at a forest plot? Anyone has any idea of what you are likely looking at? Yes, but if I ask you what's the best graphical way to compare two diagnostic tests, of course, these you see, the white, I think, is the CRP. No, the white is the procalcitonin, the black is the CRP, and you see where they are positioned in terms of odd ratio for sepsis, fine, across all studies. But does this help you deciding if one test is better than the other? It does not. You need a different display, which is the summary ROC curve. This is the kind of information that you will need to grab here. If you can then make the judgment yourself, well, that's depend on your interest, depend on the time you have to dedicate. But the basic concept, like for diagnostic, we need a summary ROC. So you can just glimpse through an article. If there's no summary ROC, it's very likely not being useful for you. Then drawing a summary ROC takes days. How you read it? Well, the closer you go to the corner, the better. Of course, you have CRP and you have PCT. The closer to the corner, the better. So here you can already tell that the continuous line is farther up left. Right? So it's possibly better. The area under the curve is larger. The test is better. The closer you are to that point, the better. And you see that the PCT is better all over. The two lines, they don't cross. So ideally, in this case, the test is best. Now, how to get there, we'll see on the third day. But we need diagnosis, evidence, to decide we go or not with a test. If we don't have a diagnosis, we can't put a treatment. Now, this patient has a PCT above cutoff, so we send blood culture, we start an antibiotic. The patient, of course, is intubated because in ICU that's almost standard, and was hypovolemic. So you order high volume fluid replacement, and you order albumin. And then one of your residents call you on the side saying, are you sure you want to order albumin? Because there is an audit ongoing and it looks like there is not so much evidence, you'll end in the spotlight. And of course, I mean, you recall vaguely that, yes, you read something and you think that albumin was working in sepsis. Actually, you are able to pull out of your memory the Cochrane review, and then when you go there on the table, really for albumin there's no effect. Seems that the effect was for the hydroxyethyl starch that you don't have available there. So, okay. So you are not anymore sure what to do. Now, what's the question at this point? If you have to frame this question in terms of PICO, what's the population? So would this be okay? Yes. What's the intervention you are interested about? Albumin. Good. Comparator? Only? Fluid. Is okay, crystalloids? Yeah, I mean, fluid. You don't kill people with water. At least you put some salt in the water. Fine. What's the outcome? Mortality. Survival would be the same, right? And what's the time frame? Well, now is okay for testing, but for treatment, you need to say, usually ICU people, they care for mortality in ICU. What happened beyond ICU is not any, I mean, of course, lifelong improvement in survival would be okay, but 1 month, this patient won't get out of ICU that quick. So this is what you search, and then you find, of course, a systematic review that look at albumin as a resuscitation fluid for patients with sepsis. And of course, the usual flow, they end with 17 studies, and for these 17 studies, they list the characteristics. And the first one you look at is there a subgroup with sepsis? And some have a subgroup with sepsis, some not. These studies were not all on patients on sepsis. Some included just patients in ICU. Maybe with sepsis, maybe not. For your question, it's important to have result reported for that subgroup, because sepsis can make a difference, of course. Can increase permeability of the vessel, and maybe albumin does work in one group and does not in the other. And then you want to have the risk of bias assessment, all what you will be learning over these 3 days in terms of how to appraise a good study. In a systematic review, usually someone else has done and has reported. Where this plot come from? Do you know this way of reporting risk of bias? This is the standard way of the Cochrane collaboration. Risk of bias tool of the Cochrane collaboration. Green dot, that domain was okay. Red, there was a serious problem. Yellow, we cannot tell. So the greener, the better. You see that in this case, the evidence was pretty good. Some of the study have no red dot at all. Most of the red dots are on the last 3 columns, those about outcome reporting. But blinding, randomization, concealment was all good. And this is the overall, this is by study. This is the average across all study. And you see that in general, there are some missing outcome, some selective reporting is not good. You may wonder why they did not report about some outcome, but in general, the studies were well done. And you see that overall, there is a small effect on survival. There are studies on both sides of the identity line. Do you know how to read a forest plot? You know this is a forest plot. Do you know how to read it? If you don't, we'll cover this afternoon, but very, very quickly, the solid line is the line of no equivalence. Whatever fall on that line, or whatever has confidence interval crossing that line, is non-conclusive. A positive study, in this case, sit on this side. So this one is a positive study. Here is the effect, and the confidence interval is all on this side. A negative study, we don't have a negative study. A study showing only arm would be like this, but on the other side. So say here with the confidence interval not getting to the line. All the others crossing the line are inconclusive. The result can be in favor on this side or against on the other side. The diamond here is the sum of all the study, and you see that is on one side, and the diamond doesn't touch, or barely touches in this case, the identity line. So there is overall an effect. If you take all of this together, there is some effect. Of course, you are interested in these studies here mostly, that are the one with subgroup of sepsis, and you see that they are like the others. One is negative. This is absolutely showing no difference, positive but not significant. This huge study here is not significant. It seems to show some effect, but is not significant, and so on. So the conclusion is there is evidence to use albumin. Is not as strong that you have to, but is not making harm. And if you have it available, is cheap enough, and blah, 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 you can use it. So you have used diagnostic to decide to give an antibiotic. Now you use evidence on treatment to decide to continue with your initial idea to give albumin. And now you have somehow saved this man, and he's ready to go. And he's father of 4, and on the day he's moved up to the ward, his wife asks you about, will he be back to be normal? What do you think? Will this young man be back to normal? Is there any long-term consequence of being in ICU with a sepsis? Any idea? Who's in ICU this rotation? You. So, what do you think? So, no impact on functional status, no impact on survival. Okay, so let's assume we want to check. Because she says, I don't think he will, I can reassure his wife, he will be okay. Now, let's say we want to check for literature, assuming someone has taken this problem seriously. What the question would be, what's the population? ICU patient? Well, is ICU patient? ICU patient at discharge. Okay, and in ICU for what? Sepsis. Okay, so adult male discharged alive, from, which is not given for taken when you are in ICU, after a sepsis. Intervention? Well, there's no intervention. You want to know what happened with time. And what's the comparator? Well, you may think at least two comparators. Sorry? Okay, so ICU patient discharged without sepsis. Yes, yes, okay. Fad was suggesting to, which I did. So one group could be ICU patient discharged with no sepsis, or sepsis patient not requiring ICU. But the first is more common. So let's say that we are interested in knowing if sepsis make a difference. And what's the outcome? Survival? Function? Okay, so survival and function. You are pretty good. You are getting almost all right. Either there was a leak in the slide, FAD, and they got the slide in advance, or they are pretty good. Which time frame? 6 months? You think that the wife would be okay with 6 months? I don't know. What do you think? 1 month? I would say 1 to 5 years. I mean, he has 4 kids. 1 month makes no difference. The wife is worried that he won't be able to do his job of husband for longer. You go, you do your systematic review, and you do your literature search, and you find a systematic review. And indeed, there are a lot of studies. You find 30 studies, and these are the studies. So we were not the first one to ask this question. Actually, this question is asked very often, and it's not so obvious. There are 30 studies, and guess what? They found almost everything. So there is someone saying 3% remain impaired, or as high as 50-something, 43% as an impairment. So 43% is almost 1 in 2. And you may say, well, why all this variability? Likely different population, different treatments, different setting, different severity of sepsis. But so what do we answer? First of all, what do you think? Is likely not to have any impact at all? Well, on average, I would say no, unless all the studies not showing any impact were not published, which case we will not find them. That's called publication bias. Do you see any reason why, if I look at a cohort of ICU patients and I find that they all do well, I would not be able to publish it? I think that many journals would be okay to get that evidence published. So I don't see a reason here for publication bias. You may imagine that as a surgeon, I would not like to publish a case series where I show I'm really bad. That's fine. It's not that the journal doesn't accept it. I'm not sending it to a journal. But if I send it, they will accept it. In this case, I don't think there is a chance of publication bias. How can you judge if this evidence is strong? Well, one way is to look at 3, 6 months, 1 year, 2 years. Here we are looking at mortality after discharge, 23 studies. And you see that there is a lot of variability. So the mortality initially is low and very compact, about 5%. Then over 2 years, it goes everywhere from 15 to about 50. The size is proportional to the size of the study. So again, I see that it increases over time, which is what I expect, so I'm reassured, but it's still very, very wide. And this is mortality after discharge. If I look at total mortality, so including in and after the hospital stay, again, I see a progression and I see less variability. So in general, I would say that the concept that our colleague proposed before is what we hope, but is not really what happened. A sizable number of patients admitted to ICU for sepsis, even if they are discharged alive and well, they have an increased mortality over time. Not clear why. You will need to go in and see that they tend to come back with subsequent episode of sepsis or tend to have mainly respiratory long-term disability. Now, survey time, cross-sectional study on you. Mostly before you move to the working group, we want to be sure you function. We don't want to see anyone falling dead when stand up to go to the small room. So you'll use your arm to answer, which is exercise. Actually, since the risk for immobility is DVT, you are allowed to answer raising your legs or feet if you want, instead of arm, but you have to answer. So the first question is, and this is for us, to understand in planning the next edition, there will be a next edition of this course, if this is learning that is needed or not. Who of you, as a routine, combine evidence for diagnosis, prognosis, and treatment in their decision? You do? Is she the only one? You do? You do. Come on, 3 only? Okay, let me phrase the question differently. Who realizes today that for your routine clinical decision, you are indeed using diagnosis, prognosis, and treatment evidence, and you didn't know that you were doing, but you are doing? Can you raise your hand? Come on, stretch your hand up high. Oh, nice, nice, like that way. Okay, a bit more. So if this is the case that you couldn't really answer, I'm doing, but you realize that you were doing, that's good. Means that we are helping you focusing on what will be the continuation of this course. The second question, who of you does use any source of pre-appraised evidence? 1, 2, come on. Up high. Who of you? 1/3 more or less. Who uses up-to-date? So, come on. More use up-to-date than sources of pre-appraised evidence. This means you don't know that up-to-date is a source of pre-appraised evidence, correct? Good. Who of you uses Dynamed Plus? No one. You, don't be shy, it's not forbidden, I think. Is a good textbook, is really quicker than up-to-date in incorporating new evidence, is less graphical, so it might be more difficult to move in, is way cheaper. If you don't have it, you may ask for a trial for the country and get it for, I can help you with that, getting for free. It's always good to have at least 2 reference textbooks. They are different, they provide slightly different view on different aspects. And they are equally good. Dynamet Plus is slightly faster. Who is registered with an evidence alerting system? Who of you receives advertising about new important studies? Okay, quite a third. Who you subscribe to? Medscape? Okay, who else? Yale. Who? Clinical Journal? Or New England? Journal Watch. Okay, so Journal Watch, Medscape, any other? These two only? Who? I don't know it, but my fault. But it gives you news about evidence published anywhere or only in the journal? Only in the journal. Okay. No, I was looking at broad alerting system. So, for example, Dynamet Plus has an alerting system where, on top of, if you register for the textbook, or if your university, your state register for the textbook, you can say, I'm a pediatrician, can you alert me anytime you change anything in the book? Can you send me an alert? Which is very good, because it helps you keeping up to date with your own. Say you are a cardiologist doing interventional cardiology. Anytime they change something in the chapter, you receive an email saying, we have included this new study, we have changed our recommendation. So you don't need to go there and read. Anytime they change, you'll know it. Medscape is a good service, but is pharma sponsored. So they live on pharma sponsoring. So you tend to receive alerts about study that pharma is somehow supporting. It doesn't necessarily mean they are bad study, but is very unlikely for you to receive an advertising of a study showing that a medication does not work. That you may go back and check. It's very, very rare on Medscape. Now, one alerting system that I'm, of course, very biased, I strongly recommend you to subscribe, is ours. We don't make any money out of your subscription. It's free, and we don't really, we make our money differently. We sell the content we select to publisher. That we do for profit. I mean, not for profit, to sustain the unit. It's a unit of 20 persons, so I need to pay their salaries, and I have revenues from Dynamet Plus, Up to Date, BMJ, to give them evidence. But for individual subscriber, we do it for free. You will see in one of the following lecture how to do it. But you may say, I want to receive alerts, and those are non-pharma sponsored. We don't get any money from pharma, and we cover about 150 journals, about 70 specialties, and you can select what you want. It's good to receive alerts. You may have no time to go and read the article, but you can read the abstract, and you know that something is there. Then stays in a repository where you can go back and check it whenever you want. I'll stop here. I think I'm on time. Yeah, I asked my third question. I don't have a thank you slide, so I'll thank you for attention. I don't know if we have time for question, if any. If not, you can ask your facilitator in the small group. We will go on working on this.
Great, thanks. So you can now break down into small groups. Just go through these double doors. Within double doors over there, you can get to the 6 small groups. I guess based on the color code that you're carrying with you around your neck, you just check which group, and then you see the signage in the room. Choose your nameplates are there, so you just sit where you've been seated, and we'll start the